You're listening to Just Medicine, an equity in healthcare podcast created by medical students in British Columbia. Hello, everyone, and welcome to the very first episode of Just Medicine. Today, we'll be chatting with Dr. Marcus Greatheart about the art of medicine in managing substance use and mental health in rural areas. Substance use is a serious problem here in BC, with more than 2,200 British Columbians lost to toxic illicit drug supply in 2021, according to the BC Coroner's Report. In the past 7 years, the rate of death due to overdose from illicit drugs has increased by more than 400%. And in terms of years of life lost, drug overdose is now second only to cancers in BC. Since the public health emergency surrounding substance use was first announced in April 2016, more than 8,800 British Columbians have been lost to drug overdoses. Between 19.6 and 26.2% of British Columbians, somewhere around 1 million people, will experience a mental illness every year. This number exponentially increases when you're looking at people with substance use disorders as well. Many of our patients with substance use and mental health disorders do not seek healthcare. This can be due to physical inaccessibility of getting to clinics or due to mistrust of healthcare workers and authorities in general because of past negative experiences. So as future physicians, we have to be aware of these barriers and actively work to address them. Dr. Greatheart is a family physician who works primarily with patients with substance use and mental health disorders. Today we chat about work-life balance, building rapport with patients, and he also shares some pearls for medical trainees. The resources that are mentioned throughout the talk are shared in the episode show notes. Enjoy the episode! Hello, everyone, and welcome to Just Medicine. My name is Shadan, and today I have a very special guest with me, Dr. Marcus Greatheart. He is a social worker and a family physician, and he is working on Vancouver Island at the moment. Hi, Dr. Greatheart. So great to have you here.
So good to be here. Thank you for inviting me.
Yeah, of course. So I just want to jump right in and ask you to tell us a little bit about yourself. You've had quite the career trajectory in medicine and in healthcare in general. So tell us a little bit about yourself and what your practice looks like right now.
Sure. So, as you said, I've had a bit of an adventure through healthcare. I worked for almost 20 years as a community health educator and social worker. And after grad school at the age of 40, I applied to medical school and ended up attending McMaster in Hamilton, actually at the Niagara Regional Campus in St. Catharines. And I was the graduated class of 2015, and then matched to St. Paul's Hospital program, where I did my family medicine training, and worked at Three Bridges Community Health Center, one of the downtown primary care clinics, where I continued to work for 5 years. Until earlier this year, I moved to northern Vancouver Island, and now I work in Campbell River. Campbell River is a couple hours north of Nanaimo, and there I have an addictions-based practice half-time, and that's for my clinic. I also work on the addictions consult service at Campbell River Hospital. And then a couple days a week, I'm part of the substance use integrated team's primary care outreach to homeless folks living in Campbell River.
That's fantastic. You're so busy. You have so many things to do.
I do. Within all of that, I still, for my own mental health and well-being, I actually have most Mondays off. So when I'm on call for the hospital, I necessarily work on Mondays. So It's sort of my extra day to get caught up. But otherwise, Mondays like today, I don't have any clinical work, and so it gives me the opportunity to have wonderful conversations like this.
It's so great to hear that, physicians, even though they are living fulfilling career lives, they also start to integrate and seeing that wave of physicians taking that time for themselves to prevent burnout and just kind of for their own mental health,
Absolutely.
keep that up.
Yeah.
Yeah.
My husband and I moved here in January with our dog, and we live on a little island near Campbell River. And as I was saying to you, I start my day but with a bike ride and a ferry trip over to Campbell River, and that's how I end my day as well, and that's how I can decompress. And we made this decision to improve our quality of life, and so I want to enjoy our decision. And so, I enjoy being at our house that needs a lot of work. And so, my husband is currently putting up some fencing, and when we're done, I'll be heading out to help him because the fence came down when the snow came down a couple of weeks ago, and we have to keep the deer out of the garden that we're putting in so that they don't munch on all the currant bushes.
Wow. Okay. Well, it's good to hear that your medical work is also integrated with some different type of work. But coming,
Absolutely.
yeah, coming back to what you were mentioning about. So, for those who don't know, Three Bridges is a primary care clinic in the core of downtown in Vancouver, and does primary care for some of the most complicated patients in downtown. They have a host of social issues such as substance use, mental health disorders, and they
Hmm.
experience poverty, homelessness, food insecurity. So it's a very I imagine fulfilling experience and a very popular elective with our fourth year students at
Hmm.
UBC.
Yes,
Yeah,
one of the most desired in the lottery electives. Yes,
yeah.
the uh, inner city medicine, as we practice it, focuses on serving patients who experience poverty and homelessness, living with substance use disorders and mental illness, and requires a robust wraparound care, which includes physicians and nurse practitioners, social workers, nurses, and a very understanding group of uh, admin support, um, and incredibly rewarding. The clients who come to that clinic, uh, as you say, are quite complex, and they actually need to meet a complexity mandate. And there are a number of measures of complexity. So, but I think listeners can probably appreciate that uh, folks who have a number of those concurrent issues going on uh, would require more care. What that means is then that others would be excluded from care. So when folks are assessed, if someone's able to actually attend a regular medical office appointment, schedule it and attend it, um, uh, that's typically somebody who wouldn't be coming to our clinic. Our folks frequently don't attend, or we send outreach workers or nurses out to provide care in the community and try and bring them into the clinic to receive the care that they need.
So that actually addresses a really important point, right? So we frequently, so I was at St. Paul's Hospital for my CTU rotation, and
Mhm.
a lot of planning does go around discharge planning and ensuring adequate follow-up. But I think what Three Bridges does really well is to really target those people that truly can't or won't, for whatever reason, seek healthcare on their own.
Right. And so when we think about why patients living with a history of addiction, mental illness, people of color, LGBTQ plus people, Indigenous Canadians, why would those patients not come to medical appointments? And I think we have to look at ourselves as care providers and think about how is it that we may have contributed to that care. I frequently say to our medical students and residents, when they're training with us that, for example, colonialism and the maltreatment of Indigenous people in Canada is woven into our white coats. Between Indian residential schools and Indian hospitals, doctors played a role in that abusive care. That abuse, as we know, much like the abuse of residential school, has had an impact on generations of Indigenous Canadians. And different yet similar, we can see the neglect and abuse of people of color and queer and trans folks, people with mental illness and addictions. There's lots of reasons why these folks, either from personal experience or stories they've heard from others, right? And there's would not access care. And there's research. Right? There's great research just came out last year around the delaying of care sought by transgender people in Ontario from the it's called TransPulse study. And so as care providers, and you're in medical school right now and you're learning about the pathophysiology of disease, right? And so I think when we are diagnosing and treating, we're aware that the disease progresses, right? And we would probably make the assumption that patients would present early on, first onset of a particular symptom, whether it's pain or what have you. But thinking that folks would actually delay care because maybe they can tolerate the pain more than they can tolerate even the worry, the anxiety around potentially being mistreated in a healthcare environment is a really interesting, concerning concept.
Yeah, for sure. And then this reluctance to seek healthcare for, like you said, myriad of reasons, depending on what kind of minority group you're in, or minority groups, if we get into the whole concept of intersectionality. That delaying of healthcare is going to lead to worse health outcomes because, like you said, that pathophysiology is going to progress without treatment and management of that condition. So I want to ask...
And also I would add to that, right, that delay in care, not just worse outcomes for that person, but use of greater resources, right? More likely to need admission to hospital, more workup, and utilization of more professional care, and greater cost to the healthcare system.
Yeah. And also just more likely to get hospitalized and have to have a longer stay, which then introduces them to a whole slew of kind of hospital-acquired infections. Mental health definitely gets affected when people are in the hospital for a long time, disruption to their daily life. So things kind of perpetuate continually if we don't stop somewhere and think, okay, what's going on at the root of the problem? And I want to talk about that. So you were mentioning, you work with a lot of underserved and marginalized groups from different walks of life. What is your kind of approach and, I guess, philosophy in understanding that, yes, as a healthcare provider and as a physician in a position of power, you have that position of power and you are a part of this infrastructure and system that previously and still contributes to violence in healthcare and kind of upholding our systemic injustices. How do you go about reconciling that with our role as healthcare providers and caring for your patients?
Right. So I recognize that mistreatment of marginalized communities is perpetuated by our professions, but also I have to assume that at times I've contributed that to myself, right? That I have dead named a trans person, even by accident. That I have, in whatever way, contributed individually to harm of patient by my actions, by my words. I also have to assume that, I'm an older white male physician, right? As you say, I have a lot of power, right? That I represent a lot of the authority figures and people who take power from our marginalized communities. So I recognize that I'm already being perceived in a place of power and as somebody who could or has perpetuated harm unintentionally. I would never obviously intentionally do that, but even in ways that I wouldn't know. So I feel like I need to always approach any interaction from a place of being humble, of recognizing that even that I might attempt to reduce or adjust the power differential, but in many ways I actually can't. I'm the one who holds the letters after my name that have significance and garner respect. I'm the one who has the power of the pen to write the prescription. So I try to meet folks really where they're at and identify, help to identify what their needs and concerns are and see what I can do to provide care. I think it's important to align myself with patients and to clarify what their concerns are. And when working with my patients, I find that I need to align myself with my patients to help get their needs met. So, in our among our patients who are experiencing homelessness, frequently access to services is difficult, right? Somebody might want a particular kind of imaging, that sort of thing. So they might want an adjustment to their methadone or other opioid treatments. And we know that we're operating with particular guidelines. We're operating under the restrictions from, say, we operate with guidelines, say, from the BC Center on Substance Use in terms of how frequently and how much we can increase methadone, right? I can't start you on 100 milligrams of methadone if you haven't been on it before. We have to start you at a lower dose and taper. I can't order an MRI for this until we get an X-ray, right? Those are things. And so I find it helpful if I work to align myself, be beside my patient and walk beside them. And I know that sounds like a bit, I think we use the term walk alongside and our patients. And how I interpret that is to say, it's you and me, right? We both want to get to a place where your pain is relieved, where we figure out what's happening with your stomach troubles, where we understand your migraines. And I'm here to help do that, but I'm also constrained by our healthcare system, which we know is imperfect, right?
Yeah.
I also tell trainees, I tell patients, they are the captain and I am the navigator and the safety officer. And so that means that I'm sort of directing us in the ways that we can help to get their needs met or understand what process is happening for them, and to guide them in terms of safe choices or safer choices than they might be making right now.
Right. So kind of restructuring the traditional doctor-patient relationship of paternalism where, it's whatever the doctor says, to empower the patients to be the captain of the ship and kind of take ownership of their health while you being having the medical knowledge and knowledge of how our healthcare system works, kind of navigating through the journey of whatever their health concerns are.
Right. And so for trainees like yourself and for residents, I think what I think is important is that I need to know the guidelines almost better, because I need to know how to maneuver through the guidelines and understand what we are and are not doing. So I think that relates to another important point. I was recently at the International Street Medicine Conference in Toronto in September of this year, 2022, and one of the speakers spoke about the importance of primary care for our patients experiencing homelessness, and how I'm mobilizing that is to say, we're frequently going out on outreach and meeting folks at some of the encampments or or around the overdose prevention sites in our community. And folks will frequently come to us with a particular concern or issue. What I'm attempting to do is to not just focus on that issue, but to look at the whole person. So if this client is coming and asking for a restart of their methadone, or they've injured themselves, burned themselves, and they need treatment of that, I'm also looking at this patient, and if she's a woman in her 50s, then I'm thinking and inquiring about, when did we do diabetes screening? When did we last check lipids? Let's get a blood pressure. Is she up to date on other preventions? Has she had a fit test? Has she had a mammogram? What about a PAP, right? So that we don't just focus on, that we want to give primacy to that issue and concern because we're wanting to build rapport and engagement. But I'm also thinking about the other common preventions and issues of family medicine. So I will often say to my patients, just because you're living with a substance use disorder or living with mental illness doesn't excuse you from the other preventions, right? When people who are sexually active get sexual health screening. People of a certain age get different kinds of screening and when it's appropriate. And so for me, that's a measure of ensuring that we're providing balanced care. And we're not just treating the opioid use disorder, right? We're trying to treat the whole person. And that might not be the primary motivation, or it might not be on the agenda of that person in the moment, but I still want us to be thinking about it and inquiring about it and saying, okay, so you haven't had a mammogram in, at all, and you're 55 years old. When the time comes and you would like to have one, then let us know, and we can work with our outreach team to help get you up to the hospital to get one done. And if it's okay, I'll check in with you about that every once in a while.
Okay, that's actually so helpful because I think when we think about, marginalized groups or underserved groups who specifically have, substance use disorders or mental health disorders, we kind of forget about, like you said, we focus on the primary presenting issue, which is also what they want to focus on. Like they want to up-titrate their methadone or try a different psychiatric medication. But it's important to have that comprehensive care for, again, thinking about health equity and health outcomes. A lot of people who are marginalized aren't seeking care regularly to get those screening programs and screening tests done. So I really like that method of, I know that this isn't your primary concern right now, but it is something that I would do for any patient. And whenever you're ready, let's talk about it. And the frequent follow-up from your end, not kind of hounding them about it, but just keeping it in the on the list of things that need to be done is such a great way to incorporate holistic care.
Right. And I'm a family doctor, so I need to do the things that family doctors do. And family doctors attend to the concerns of our patients. And we also, as a family doctor, I want to attend to the immediate concerns of my patients. And I also have a responsibility of monitoring and monitoring for the disease prevention that we do.
Right. So you've worked at both a big clinic in core of the downtown of Vancouver, and now you're working in a rural setting with different and maybe more limited resources. Can you speak a little bit about how does your practice differ? Because you're still kind of working with with similar populations, but how has it differed now that you're in a different setting?
Great question. When I left Vancouver, not just for this opportunity, I did also feel like I wanted to spread my wings. I felt I had learned an awful lot working in downtown Vancouver, inner city medicine, at St. Paul's Hospital, And I really wanted to take that learning from to a smaller community. I was fortunate to be connected actually through one of my residency mates. Um, Dr. Laura McKinnon connected me with the team up in Campbell River, and I ended up stepping into a locum position for one of the addictions doctors there, which provided this opportunity for me to find my bearings and get to know the community. What's different for me is I work in a very busy, primarily addictions clinic, where we have primary care attachment with our nurse practitioners, and the physicians are doing addictions focused care, which means I'm providing a lot of OAT, opioid agonist therapy. And starting very soon, in the next few weeks, we're going to be starting a safe supply program with fentanyl patch, and perhaps expanding next year with a funding program through AVI, which is very exciting. So rather than having, as you will when you're at Three Bridges, longer, up to 30-minute appointments with patients to be able to provide that robust care, I'm writing a lot of prescriptions because we have a huge need and limited physician capacity. So my clinic is basically 2 days a week, a drop-in for our patients to come in to provide them with their prescriptions, and adjust doses, that sort of thing. And I'm doing what primary care I can in between. It can be a bit chaotic at times, and very busy and very slow, depending on the time of day and the day of the month. And it's rewarding in its own way. It can be stressful, and yet I recognize there's such a huge number of folks who need opioid agonist therapy, that in the times where I feel like it's a little bit of a, at times I feel like it's a bit of a Ferris wheel no, sorry. At times I feel like it's a bit of a conveyor belt of patients coming through for prescriptions. But again, I reflect that it's important that people get their prescriptions from a provider that they trust and know. And I think my patients appreciate my approach, and they, I think we've built rapport even over the short time that I've been there, and I've seen some wonderful improvements and patients achieving their goals. Different in this clinic, as I'm sort of clinically specific, is that we're using a lot more Sublocade. Sublocade is the injectable version of buprenorphine, which is folks might be familiar with Suboxone, which is the sublingual tablet treatment for opioid agonist therapy. And so I have quite a few patients now that we've converted over to Suboxone and onto Sublocade. So that's been very exciting, and that is life-changing for folks. We do have some access to, through our addiction service at the hospital, we've had some folks who while they were admitted to hospital, we were also able to convert them over to Suboxone and Sublocade. And so that's been great and very hands-on. The other part of the outreach work, I mean, I hadn't done outreach work before, so now 2 days a week, I'm out in the community with our team of nurses and social workers and Indigenous patient navigators to find folks where they're at. And that's been incredibly rewarding. I would say some of the most rewarding work that I've been doing is to provide some wound care at somebody's tent, to hear folks say, wow, we never thought a doctor would come out and see us here and provide care here in a backwooded area near a park where our homeless folks have set up a camp. In and are living in tension with the community and with City Hall. That's pretty extraordinary work to be doing, and I'm so blessed to be working with a great team of nurses and our outreach team there who are jumping in there and doing some advanced wound care and addiction support and mental health assessments. We're uh, more recently doing some palliative care for homeless folks. Uh, it it's amazing and life changing. And I come home at the end of the day, and I my husband sees how how nurtured my soul is by this work, which is incredibly complex. Uh, I think about the gifts of my training, right? I'm a social worker and a doctor, and that like Venn diagram. I always say that Venn diagram is like the unicorn horn, and uh, that's in part what enables me to do this work. And it fills my heart.
That's so fantastic. I didn't know about this outreach program, and it's such a kind of great initiative, again, thinking about the barriers of why people don't access
Hmm.
healthcare. Um,
Yeah.
it's you're targeting the root, as I always say, of okay, they physically can't get to the clinic, so we will go out to them. And it's just such a great example of the way we can come up with initiatives that target the specific cause of and barrier that we're facing, or this group is facing. And that's why I think it's so important for us as for me as a medical student and then resident and a future physician to kind of start creating that awareness for myself of like, what are the barriers, so that then I
Hmm.
can be a part of this team that focuses to address these barriers at their root. I want to ask you, as someone who's been practicing in a smaller community, um, focusing on addictions, what are the biggest barriers you've seen or you've heard your patients complain about in accessing regular healthcare and also addictions or mental health specific healthcare?
Well, as we know, access to primary care in Canada broadly is growing increasingly difficult for the average person. Um, I have um, a new family doctor here who I met once when and then who then went on maternity leave and said, my colleagues are covering, and but anticipate it's going to be 4 to 6 weeks before you can get an appointment to see somebody, and I'll see you in a year. That's the reality for many of us, right? I'm hearing colleagues saying, who work in healthcare. One recently said that they were fired by their doctor because they hadn't been seen in a couple of years, and she said, I've been healthy. I haven't needed to go to the doctor. So many folks, doctors have stopped practicing, retiring, switching, right? So a lot of what we're hearing about in the news right now in BC and elsewhere around finding a family doctor is the reality for all of us, because we're all patients, right? But even more so for folks who are experiencing mental illness, addiction, uh, homelessness, and poverty. Our patients are struggling to get to our clinic because they don't have transportation. Um, our folks lose their bus passes or don't get their bus passes, or they don't have the ID that they need. We had a client recently needed to get a birth certificate from another province, and that took 3 4 months to get a birth certificate, and it was so complicated. And between myself and our social worker and the client, like I can't even tell you how much work that took to do so that we could get them onto a medical services plan here. And we begged for extensions. We uh, in order to have some like of the temporary coverage. So our clients frequently don't have a lot of skills or access to be able to do that kind of self-advocacy. There are specialists uh, here and in Vancouver who basically require an email address in order to be able to communicate with patients. And many of our folks don't have a phone, they don't have a computer, they don't have an email access or the technical knowledge to be able to do that. We do ourselves a disservice when we assume that everybody's able to do that. And maybe that does help with some clinics, but you also need to be able to find other ways to communicate with clients. So we we do things differently. I send a referral and I say this patient is followed by the by our suit team, the outreach team. Please send appointment details to the case manager. The case manager will ensure that we outreach to that client and that we transport and bring them to the appointment. And if needed, we'll even sort of sit and chaperone that appointment if the patient would struggle to wait in a waiting room or want an advocate to come into the appointment. I think that gives you a bit of a sense of some of the many barriers. I would say I'm spending much of my care for patients thinking about how do we do this in their life circumstance. So, you will write plenty of prescriptions for antibiotics that, for infections that are required 4 times a day. Well, our patients can't take meds 4 times a day frequently. Some can. So I'm frequently thinking about like, how can I adjust to this prescription? Maybe it's not ideal. Is there another antibiotic that I could choose that's once a day? So cefadroxil is one of our new favorite antibiotics, not carried by all the pharmacies, but I've called the pharmacies that I typically work with and asked them to stock it because it's a once a day. It can be used in certain situations. Yeah, are there different ways that I can treat a particular condition that are going to align, in particular, for folks who are visiting the pharmacy daily for their OAT, that I can tack a medication on there? Or recently I had a patient who was concerned about sexually transmitted infection, and it seemed like it. And I said, if I need to make an adjustment to this, I will communicate that to you through the pharmacist, and got consent. And so I ended up having to make an adjustment to the antibiotics, and that's how we figured that out. So I'm constantly thinking about and talking to my patients about what are the potential barriers, what are the things that are going to potentially happen that might get in the way of a successful treatment or management of this condition, and then trying to problem solve that, and calling community partners, and knowing who I can rely on, and who can advocate for this person, or who can give them a lift.
It's really the art of medicine, what I'm kind of hearing you describe. It's to apply the medical principle of an infection needs an antibiotic, but also to apply it to this individualized patient context of, okay, this person is not going to be able to take 4 medications or 4 pills a day. And honestly, it's not even so much of like a specifically of an unhoused individual or someone who has substance use or mental health. Even people without any of those conditions won't take medications 4 times a day, mm-hmm. right? So it's just having that kind of knowledge and awareness of that. How do I make this easier for my patients to improve their outcomes, and then apply that to a patient-specific scenario? And like you said, applying the earlier principle you mentioned of walking alongside with the patient, asking them, okay, what are the barriers for you to get this treatment done, for you to feel better, and working together and with other allied health professionals and people in the community. I think it's such a great example of what your approach is. So I really appreciate you sharing that.
Thanks.
I want to ask you, what are some resources, whether it be articles or textbooks or papers, anything that you can think of for medical students and residents who are interested in learning more about kind of, again, the art of medicine, not so much, what are the medications and what are the doses that you would be using in like opioid agonist therapy, but what are the things that you would recommend people to read about and learn more about when thinking about how to work with the patients and not so much of the medicine.
Right. Um, Much has been said about trauma-informed care and what that looks like. I think trauma-informed care is growing in terms of the respect it's getting within healthcare. There will always be detractors to that, but I think fundamentally that's an important component of what we do. I operate with the assumption that all of my patients have experienced some trauma and experienced sort of trauma in general, whether that's early childhood or through their adult life, particularly if they're experiencing homelessness and addiction. There's a lot of terrible things that happen to folks, as well as trauma within healthcare settings. So I think starting from that basis is important. I think about learning good communication skills. I think, for example, from Ariadne Labs, the serious illness conversation is a wonderful tool, and it's geared towards having discussions with patients around what their wishes would be, their fears are, who their supports are when they have a life-limiting illness. But I think that concept is expansive, right? That can be used in all sorts of situations. So those are the kinds of questions that I ask when I'm doing a new intake for a patient for starting on, when they're starting on their methadone. I want to know who. So it's not just like, who is your family in town, but just because you have family in town doesn't mean that you're close to them. Like, who do you turn to when you need support? Those sorts of questions really drill down to help understand what's going on for a person. So finding those types of communication tools, like the serious illness conversation, that we can adapt, that help us be patient-centered. I think the challenge for medical students and residents is that the educational institutions are needing for you to learn particular knowledge, and because of the way that you're frequently evaluated, particularly in exam settings, you kind of need to do it in that structured way, which again is very useful to know, right? You need to know what the rules are, what the guidelines say, before you can then bend them. So I don't know that the exam answer is ever going to be trauma-informed care, but the question is, how can you do the role that you need to do, get the information that you need, provide the care that you need, at the same time as being patient-centered and empathetic, right? There's a great book called Compassionomics, which talks about the value of compassion in healthcare, and he really looks at the evidence for compassion in the work that we do, and breaks down these myths that being more compassionate or empathetic actually costs more or wastes time, that sort of thing. And it's actually I find it kind of a fascinating take on healthcare, and how we can. It seems I can understand. It seems a bit counterintuitive to say that if I spend more time talking to my patient, and providing empathy and compassion, that I'll actually be able to do a better job. I think what we're aiming for is to be effective and efficient. And there's lots of evidence, and Compassionomics is just one of a number of resources. There's also the Cleveland Clinic has a patient interview guide called it's Ready, I think, REDE, which focuses, which highlights how physicians can be both effective and efficient. So you'll remember from your first year communication skills course, which I've taught, the rule of interruption, right? That we interrupt our patients within the first, I don't know, I think it started at 23 seconds, and it's actually, even though there was a study that said the original time was, I think, 23 seconds, and then we all learned about it in med school, or they learned about it through the 90s and 2000s, and then they went back and reevaluated and figured out that we are actually worse at it, that we're interrupting our patients now at an even shorter period of time. The benefit of allowing patients to talk longer and uninterrupted initially is actually we get to both their primary, we get their first issue as well as their primary issue, because the first issue is typically not the primary issue about why they came into the appointment. But also we can make a more effective agenda, right? So just starting with that, we're already setting ourselves up for greater success in that clinical intervention. We're just living in tension, right? Because we're doctors and we've got people in the waiting room and the phone is ringing and we're on call. And it just feels like if we can take control of that interaction, that we can, it'll be more effective if we're in control. But the reality is that we give control to our patients to tell their stories, at least initially. And then we do some agenda setting around the parameters of the appointment and what we're there to achieve and do and get our patients online. And that way we can also build trust. We build trust with our patients. They're more willing to share with us the information that might feel embarrassing or awkward to share. That helps us in our diagnosis. So there's so much evidence to say that compassion, empathy, rapport, that building skills in doctor-patient communication, nurturing the relationship we have with the patient, even if we're just meeting them once in the ER, is foundational in being more effective and efficient. That the time we spend investing in communicating better and in building rapport helps us be better doctors because we understand better what's going on and saves us time and time in droves, going forward.
I think that's a really important principle to remember when, especially as medical students and residents, we do most of our training in the hospitals, which, like you said, there is, you're on call, you're seeing a patient, there is another patient maybe waiting for you if it's a particularly busy night. So to take that extra, whatever it is, 30 seconds, 5 minutes to really hone in that communication and rapport, takes us that extra mile, which is really good to hear from someone who's been doing this for a while and who has really good rapport with some of the most underserved and marginalized patient populations. So I think it's a really good pearl to keep in mind. And speaking of pearls, we've had such great conversation. We've really spanned huge topics. So I want to close the conversation like we do in our lectures and first and second year and in medicine as a whole, with some pearls that you would want to share with medical students and residents and medical trainees in general, as to what they should take away from this conversation and what they can try to incorporate into their practice.
Well, I think you don't need to get a master's in social work to be an effective doctor. It sure helps. More importantly, it's given me uh, a lens upon the work that we do. I think this idea that, I go back to the SOAP note, right? The subjective, objective assessment and plan, right? This objective, I think this idea of objectivity is actually, false, right? Um, a blood pressure is not just a blood pressure, it has to be seen in context, right? And that context is processed through our brains, right? Um, so I think what's important is that we consider the clinical lens that we bring, the critical lens that we bring to our clinical work. The critical lens that we bring to our work, when we are aware of that, helps us to identify some of these social issues, some of the psychosocial issues that interact with our patient's ability to share their stories, to participate in a treatment plan, to follow through with taking their medications. I think it means we need to, so the pearl in that is self-awareness and self-reflection. What do I believe? Do I believe in harm reduction? Do I believe in patient autonomy? Do I, I often say to colleagues and trainees alike, patients are allowed to make choices that we would consider unwise, right? We can't force patients to do things that they don't want to do unless they're certified under the Mental Health Act, right? In which case we can give them psychiatric medications, right? We can't force people to undergo medical interventions. And we might think it's unwise and we might not understand their choices, but they have the right to do that, much like we do, right? Their autonomy is super important. So I think having the ability to self-reflect on our investment on, I want to figure out, I need to know the cause of this and I need to provide the treatment and it needs to be successful and this patient needs to be cured, right? Life's not that simple. So understanding that we're on a journey with our patients and we're going to get where we get. And that journey might lead to treatment and resolution. It will hopefully evolve some relationship. At the same time, it might lead to a worsening of a patient's health condition and it might lead to their death. And those are all parts of the reality of the work that we do. And I'm okay with that. And I try to do that again by reflecting for myself, by setting a high bar for my clinical practice. I will, in situations, frequently think about the mentors, the people who trained me, the doctors whom I respect, who I still talk to frequently. And I think, in my family practice, I think of my mentor, Dr. Tanya Cullum at Three Bridges, who supported me and taught me so much. And so if I'm in a bit of a dilemma, I think, well, what would Tanya say or do in this situation, right? Would she would she uh, would she support my choices, my clinical choices and decision making here? And sometimes when I'm not sure, I'll call her. Hey, I'm in a I'm in a pickle, and I have other folks, right? The gift of medical school and the gift of residency is that you meet folks, mentors and colleagues who you can call, right? I have another colleague if I'm in a bit of an ethical dilemma. I have like people I can call and say, I'm in this ethical dilemma and I need your blunt take on this because I'm obviously enmeshed in what's going on because I'm the care provider and there might be personality components, what have you, going on. And so I think it's important to have those people that you can trust. I think when you're training, having a team of colleagues who you can say, like, you can call me at 3 o'clock in the morning when you're on call and you don't know what to do and you just need to talk something out because you have to go and present to the staff and you're going to do the same, and I'll do the same for you and you're going to do that for me. right? I think that our current residents, they have sort of a WhatsApp, and so it's, they'll text the group, and there's always somebody else awake, or somebody who will respond, right? That you have each other's backs. So I know that there's a group of docs out there who will answer. If I were to call at 3 o'clock in the morning, they would answer the phone and they would help me out, just as I would do that for them. And that's about relationship too.
Yeah. So self-reflection and finding your people.
Finding your people and finding, yeah, you have the gift of as you're moving through residency, I think, well, at least in family medicine, your first year is learning family medicine, and then you're fine tuning, and then I believe you're building, praxis. Praxis is a term from social work, but it's like how you practice medicine. It's not which antibiotic you choose for a UTI. It's how you see family medicine and how you engage with your patients and your colleagues and do the work in your day to day, living with integrity and, holding up the bar for yourself and for the trainees who are working with you.
What a good note to finish us off. I just want to thank you so much again, Marcus, for coming on and chatting with us.
My pleasure.
It's been wonderful to just learn with you and from you, and to just see a whole different kind of side of, again, the art of medicine. So thank you so much again for coming on and being a guest on our first episode here.
My pleasure.
Thanks for tuning in to Just Medicine.